Welcome to the LDN Radio Show, brought to you by the LDN Research Trust. I'm your host, Linda Elsiegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. Today I'd like to welcome back our guest, Erin. Thank you for joining us today, Erin.
Thank you for having me.
Now, Erin is a doctor of pharmacy, and I'd like you to give us your background information. I mean, had you always wanted to be a pharmacist as a child?
Oh, sure. Actually, I wanted to be a doctor first and foremost, but when I got into college, I did an internship in the ER and figured out really quickly that I am bad at, I tend to pass out when there's anything bloody or anything like that. So I figured it wasn't the right path for me. So I kind of figured a more not hands-on approach literally would be a little bit better. And my mom was a pharmacist, and I went and shadowed her a few times, and I just thought it was really neat on the knowledge of medications and what they were doing. And I thought it was a really fun field to get into. So that's when I went to pharmacy school. And then with compounding, I had a rotation in my 6th year of compounding, or in my 6th year of pharmacy school, I had a compounding rotation, and I just thought it was so fun. I'm like, it's something new every day. We get to figure out problems. You know, you get the best phone calls of just people trying to figure out what to do or how to get medications, either themselves or for their pets or for their kids or for their mom. So really helping to help somebody figure something out was a lot of fun for me. And it's to this day, it's still something I enjoy the most about the job, just trying to figure out, you know, we always get the patients that have trouble finding help anywhere else, and we're always able to try and help them. So it's a very rewarding and fun job, and I've been doing it now for 17 years.
Mm-hmm. Could you explain to our listeners what it is that you do in pharmacy school and how many years? I know you said in your 6th year, I believe it's 7, isn't it?
Now it's 7. Yeah. So back when I went to school, it was 6. And each schools are a little bit different. I went to a pharmacy school that you could start from day one and just finish in it. Whereas a lot of other places have where you do like a pre-pharm program. So you might do 2 or 4 years in pre-pharm and then actually enter the pharmacy school for 3 or 4 years. So mine was 6 years. And then I did a residency training afterwards. So that was at the VA. It didn't really have anything to do with compounding. I learned that afterwards I kind of switched over to compounding, but I did some more residency training after school, and some people do a year or 2. I did 1 year, and then I just entered straight into compounding from there.
Mm-hmm. And what kind of things do you learn in pharmacy school initially? Just walk us through it so we can understand, you know, what training a pharmacist has to have.
Oh, sure.
Become a compounding pharmacy.
Yeah. So honestly, it's not a lot of compounding. So we have students on site, so I still get to kind of see exactly what they're going through every year, even though I've been out of school so long. So generally, it's still about the same. You get a class on compounding, one class out of kind of those 6 or 7 years, and you learn kind of the basics. I think the pharmacy school here, they have a couple newer machines and technology that we use currently, but like back when I went to school, it was all very antiquated in terms of what they taught you for compounding, because they didn't teach you much on it. So it was still using an old ointment slab and very sort of old school pharmacy. Whereas now I always talk about compounding being old school pharmacy, but with new inventions and fancier machines to kind of help us do it and make it a little bit more accurate and a little bit faster. So a lot of pharmacy school is going through all these other medications that you would see anywhere else, whether it be at the hospital, at Walgreens, at CVS, going through different medical conditions and learning about those, learning how the drugs work for those conditions, learning how the drugs work in the body and how they break down and get to the different tissue level. But it definitely doesn't prepare you fully for compounding. I always say when somebody comes to work for us, it's about a 75% on the job experience training, because with compounding, there's a lot of stuff out there that people haven't done before. So a lot of what I depend on is kind of a network of compounders that you can communicate with. So I'm part of a listserv of compounders from across the world. And people would just kind of sometimes send an email out to everybody like, I have a patient that needs this. I can't find any data on it. What have people done? So you kind of take your background information of conditions and different disease states and things like that. And then you take your information of the drugs that you're able to utilize or the bulk chemical powders that you're able to get. And through that information, sometimes you just kind of have to figure out a unique way to give the medication to the patient or a unique dosage form or something like that. So it's a lot of on the job training. And it's one of those jobs that the longer you do it, the better you are at it because you've just seen more. So you've just seen more things. You've done a lot more, but it's fun from the get-go, but you definitely, as experience goes along, you definitely get more used to some of the questions a little bit faster at being able to figure out some of the problems.
And what about drug interactions? I mean, that must be part of your course.
It definitely is. And it's one of the more trickier parts, to be honest, because being a cash only pharmacy, we do have to make sure to take a pretty good medication history with the patients. With people that bill insurance, a lot of times insurance does that drug utilization review and that interaction review for you automatically. So when you bill the insurance company, it will see, even if the patient didn't get that drug at your pharmacy, it will see they got it at another pharmacy and it will alert you to the fact that it's going to interact. Here we don't have that because we're just cash only and we don't bill insurance on that, but we're able to kind of take a thorough medication history of the patients. And there's a lot of stuff that are your common interactors that will interact with a lot of drugs. So anytime we see that, we always make sure to be even more thorough and just make sure that they give us everything that they're on so that we know to be able to check through those interactions and make sure it's not something that's not going to work out for the patient.
Mm-hmm. So in your pharmacy, just go through the different options that you can have for LDN.
Oh, sure. For LDN, our most common form is tablets because a lot of times patients are going to start out on a lower dose and then work up on the dose. So tablets make it very convenient because you can split them in half. I even have some patients that split them in quarters. So therefore they can start with one tablet or a half tablet and then increase up as gradually as they need to do to reach their target dose. So I do find the tablets are the easiest and they are the most common with us. We also do capsules. Capsules, the only downfall with that is you can't really split them. So you can't split the capsules in half. So you're kind of stuck with doing one or two or three multiples or something like that. We can do different liquids. Liquids are nice in terms of being able to dose them because with liquids, the options are endless. If you have a 1 milligram per 1 milliliter, you could use 1 ml to get the 1 milligram dose. If you wanted to start at 0.1 milligrams, you'd only have to use 0.1 ml. If you wanted to go up to a target dose of 4.5, then you could go up to 4.5 mLs. So you could do all your doses with just one liquid. The only downfalls there are taste. If somebody doesn't like the taste of it, it's not the worst tasting medicine. It's not the best tasting medicine, but everybody's different on their palatability tolerances. So you've got that excipients. If somebody is sensitive to the excipients, storage, it's not as convenient. Some of them are room temperature, but still just keeping a liquid around can also be a little messy. If you spill some, it can be sticky. So, a lot of times people just prefer taking a tablet or a capsule over a liquid. We've also done creams. So any sort of topical, we can do gels and creams. There is a LDN eye drop. That is something we were looking into providing to patients. Being an eye drop, it definitely comes with a little more stringent rules and testing and things like that. We do have a sterile room that we can make it in. It's just about getting the formula down and getting the testing done on it and getting that out to patients. Feel like I'm missing one. Suppositories. I mean, LDN I've seen done in almost every single dosage form we have available. We've done a sublingual, so something that you can dissolve underneath your tongue. So if some patients, they might get some GI side effects from naltrexone. So the sublingual dosing under the tongue is a good way to help mitigate those side effects. And I think I've covered most of what I've seen. Pretty much all of
Okay.
those are options.
So what about fillers that you use in your preparations?
Sure. So with fillers, our most common one is cellulose. We do have some patients that are allergic to cellulose, and from there, if they need something else done, we definitely work with them. But generally, if just a naltrexone script comes across, we're going to default it to that unless the doctor or the patient has alerted to us that the patient needs to be worked with and they don't want a cellulose filler. So a lot of times we'll work with a patient and see what they want or need. So whether it be with a capsule, the possibilities are pretty much endless. We can choose something of their liking. Probably the second most common would be rice flour. We see that a lot, but we can also do tapioca. I've done inulin before, crushed salt, arrowroot, all sorts of different fillers, oat flour, and so the possibilities are pretty endless with capsules. Fillers on liquids get a little trickier. Naltrexone is water soluble, so theoretically you can just put the naltrexone in water and dispense it to the patient. But when it's just in water without a preservative, it can only be good for 14 days and it has to be refrigerated. So not only do they have to get it refilled every 14 days, but they have to pay for it every 14 days. So that can get a little cost prohibitive, considering a lot of times we're dispensing up to 3 months for a patient and not just 14 days at a time. Fillers for non-water liquids, we can do an oil if they're tolerant of different oils. Again, we just come across the different palatability and tolerances. Some people just don't like that oil feel. And then there is another liquid that's available. It has data on it, and it's a little bit better mouthfeel, but it does have different excipients in it that people just may not be able to tolerate. So lots of different options that we definitely can work with patients on, to trying to figure out what's going to work best with them, because we definitely want them to get the advantage of the medicine without reacting to the excipients, because then that doesn't help the patient at all. So we definitely want to make sure that they're going to get the advantage of the medication.
Mm-hmm. And what disease states would you say mainly your patients are using LDN for?
The most common that we see, any sort of autoimmune disease, and that can kind of run the gamut. We have some doctors that if their patient has any sort of autoimmune condition, low-dose naltrexone is one of the first lines for them. GI diseases, so anything from ulcerative colitis to Crohn's, IBS, IBD, we see a lot of naltrexone for that. Restless leg syndrome is another common one. Fertility, we see a lot in women's health, and we have some doctors that will prescribe it for patients that are having trouble conceiving, having trouble keeping pregnancies, or having a lot of miscarriages. And depression, we see it for that from some different psychiatrists around town. Those are probably the most common ones that we see. And then you'll have kind of random ones thrown out there because it can be used for so many different things. Pain is actually another one. So we see it a lot for anything from fibromyalgia to nerve pain to CRPS, chronic regional pain syndrome. So we do see it a lot for pain too. I think those are the main things that we see, but it definitely doesn't encompass everything it can be used for.
Mm-hmm. And when you talk to patients, what do you tell them about LDN and the expectations? Because I mean, some people are so desperate to find an answer, they want it to work on day one.
Oh, I know. I feel so bad when I tell them it's probably not going to be day one. We definitely, this can take several weeks to work. It is definitely working. It's not just a band-aid. It's helping to work in the underlying mechanisms with inflammation and modulating the immune system. I have had some patients call me like after one day and they're like, this stuff is miraculous, but that is definitely not the norm. Normally it's going to take a little bit to work. And some patients get frustrated because, like you said, they're so ready to have an answer and they want to feel better, so they've already been through so many other things. But generally I always tell patients, give it a good 3-month trial at your full dose. Don't just give the 1 milligram a shot for 2 weeks. Make sure to work up, if you're able to tolerate it, make sure to work up to that and then give it a good shot at the full dose. And I tell them it's not going to work for everybody, but it definitely is a great option that we've seen change lives. So considering the fact that it's not expensive, the side effects are minimal and mild generally. So I always tell them it's worth a shot, especially with some of these patients that have just been through the gamut on doctors and treatments and things like that. So a lot of them do give it a shot. We see it very successful in a lot of patients. And then I have some patients that will stop it just to see, like, oh, I think I can come off of it now. And they're like, oh no, I can't. I need that back. And so they'll come and like, I thought I could come off of it. No, I feel much better on it. So it kind of helps confirm and reaffirm to them that it is really helping them out.
Well, I've been taking LDN nearly 20 years, and people, are worried about the long-term effect of taking LDN. But LDN generally is in your system for like 4 hours. So every day you're getting like a 20-hour break. Mm-hmm. But what do you say to people when they ask, how long can you take LDN for?
Oh, absolutely. So it's been studied in low dose now for probably about 40 years. So I always tell them that, we do have data over 40 years now, and that it's still not really showing any long-term adverse effects, and that really the benefits of it should outweigh any potential, again, and I can't even really think of any long-term effects that they've seen from it from patients being on it for a long time. So you get those side effects at the beginning. Whenever you're on it, you might have some of those as you're working up, but generally I'm not seeing, and I don't think there's any data out there on the long term that there is any harm to taking it long term. So I think after 40 years of studies, and I always refer them to the LDN Research Trust because it kind of shows all of the different studies and things that have been done on it, and they love that source because a lot of my patients want to look up this and they haven't heard of it before, so they'll see the studies for themselves and see what it's all being done in and see the adverse effects of it and everything like that. So that helps give them a little peace of mind also. So I think that does help, but they're also used to, here in America, we've got all those commercials on TV and these drugs that come up, and all the side effects are like death and brain tumors and all this. So I think it always helps them too. That's like, we haven't seen any of that with this over 40 plus years. So I think you can feel a little better with that also.
Well, being English, when I come to America and you have a lot of commercials on your stations, and there's a really nice advert promoting some drug, and then very quickly at the end it's there and they
I know, yeah,
but it's very quickly, and they're saying, and possible side effects could be heart attack, stroke, cancers.
I know, it's terrible.
And possible death. And you think, why would anybody now, after such a lovely advert that makes you, you're going to feel so much better, and this, that, and the other, and that you could die.
I know. But yet people just remember that jingle or something like that was at the beginning.
Yeah. So with LDN, when you said that you could potentially have some side effects while you're titrating up when you first start LDN, what do you tell people those side effects could possibly be?
I definitely see vivid dreams the most. So a lot of times I'll warn them about the vivid dreams right off the bat. And a lot of times the doctors have done that warning too. It seems to be the most common one that the doctors warn them about too. We have seen that it works as well in the morning. So a lot of doctors will just proactively write for it in the morning rather than having a patient take it at bedtime. But it does work on those endorphins that come out at night. So it does make sense that the dreams would be more vivid because those endorphins are coming out then. But I tell them that's the most common. Sometimes the majority that I see might be dizziness, jitteriness, some stomach effects, constipation, diarrhea, stomach upset, just general stomach upset is one of the main ones. So I tell them it's fairly mild, but if they do experience it, give it a couple days before they increase it. Hopefully those side effects will kind of disappear. If they don't, and if they're up at a dose like 3 to 4 milligrams or something like that, that might be the dose they stay on. We don't have everybody that gets up to the target dose of the 4.5, but that may just be something they have to do lower than that. Seen a couple people with anxiety, but I don't see that as much. But it's definitely the vivid dreams that come out probably more than anything, but usually that can be pretty mitigated by taking it in the morning.
I've had some personally, I never had vivid dreams, But
Oh,
some
really?
people say that these dreams are so fantastic, they don't want them to end, and they're so
I have had a couple
disappointed.
of people that enjoy it. So
Yes.
I'm like, well, if you want to take it at night, you go for it. That's fine.
But I'm sure that your body gets used to it and the vivid dreams stop anyway.
Mhm. Yeah.
But it's good if you can enjoy it while you can. I mean,
Right.
I can't really remember dreaming. I can probably remember, one dream every 3 years. I'm sure I dream, but I just can't remember. So could you tell us what you think is the most common dose when somebody is stabilized on LDN?
4.5 is definitely the most common we see. A lot of our patients are able to get up to 4.5. So that's by far the most common that we do. The 1 milligram and the 4.5 are probably the two most common doses that we do. The 1 milligram for when they're just starting to work up and they need that smaller dose to be able to tailor their workup. But then the 4.5, we do have a majority of patients that tolerate it and that are able to stay on the 4.5. The 2 to the 4 milligrams, anywhere in there. So whether it be 2, 2.5, 3, 3.54. We do have some patients that just stay on there, and that they're probably all about the same, to be honest. It seems like our majority of patients are outside or at the 4.5, and then after that, it's anywhere from 2 to 4. And those are all about the same in terms of quantities and where patients are stable. So 4.5 is generally the most common.
Now, there are a few doctors that will prescribe a higher dose than 4.5. Do any of your doctors do that?
They do. So not as much. I do see it every once in a while, like a 4.5 twice daily. So we do have some doctors, and every once in a while, we do have some doctors that will go up to a 5 or a 6. So I do see the 5 or the 6 just in some doctors and patients that they're so close on the 4.5. They have faith that that 5 or that 6 is going to really push them to feeling they're optimal. And so when they get put on the 5 or the 6 and they find it works better for them, so they do stay on that. So we do see that every once in a while. I don't know if there's much data on going above 4.5, but we do see it every once in a while for patients or doctors that think that extra little push will help out.
Mm-hmm. Well, thank you very much for having joined us today and sharing your experience. It's been very educational.
Well, thank you. I appreciate you having me.
Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.